I'm Andrew Cook, and I'm Senior Lecturer at UCL's Institute of Cardiovascular Science in London, UK. And in this session, I'd like to describe to you the anatomy of the atrial septum, and in particular, the anatomy relevant to closure of both patent foramen ovale and atrial septal defect. I'm going to divide my talk into 4 parts. First of all, we're going to look briefly at development of the atrial septum before we move on to look at the structure of intact septal structures and their relationship to surrounding cardiac components, before we finally move on to look at the various types of defect. If we look at our traditional concepts of atrial septal development, then many of these, in fact, are correct and still stand good. So these older drawings on the left-hand side showing the 2 parts, the primary and the secondary septum, growing into the atrial chambers are still valid. And on the right-hand side, you can see here the beginning of atrial septation. You can see the primary atrial septum with its mesenchymal cap growing down between the right and the left atrium in a mouse embryo. And if we look at those in a little bit more detail, in a diagrammatic form, then we can appreciate the contribution of these structures to the fully formed atrial septum. So you'll see at this stage we have an embryo with a common opening to the systemic veins, the common venous sinus. We have a single orifice or a common pulmonary vein at this stage, and this is the period where we would have downgrowth of the primary atrial septum. So here you can see the septal structure growing downwards between the atrial chambers, and on the end of that structure we have a mesenchymal mass of cells, or a mesenchymal cap. And that is growing towards the atrioventricular cushions, which are also mesenchymal in structure. And these structures are joined by a third mesenchymal mass, which is coming in and growing inferiorly into the atrial chambers. And in the past, this has been called the vestibular spine. More recently, this has been termed the dorsal mesenchymal protrusion, or DMP, and we know that these cells originate from the secondary heart field. And these are coming together to close off the primary foramen, or the ostium primum. If we look slightly later in development, you'll see that those mesenchymal masses have come together. The pulmonary veins have begun to be incorporated into the left atrium, and we have fusion of the mesenchymal masses within the center of the heart. At this stage, of course, the primary atrial septum has to break down in its upper margin in order to get flow into the left side of the heart, and this forms the secondary foramen, or ostium secundum. But as yet we have no evidence, no formation of the secondary septum. And it's only really much later in development, when we have full incorporation of the pulmonary veins within the left atrium, that we begin to see a fold developing between the 2 atrial chambers. And this is what is known as the secondary septum. And then, of course, we have the primary septum, which forms the flap valve, and in between those 2 structures we have the ostium secundum, otherwise known as the oval foramen. Now, more anteriorly, the mesenchymal masses, which fuse together, help to form the base of the atrial septum, which is essentially muscular. It helps to form the eustachian ridge, and within it the tendon of Todaro, and then more anteriorly will help to form the fold, which is known as the muscular AV septum. And in fact, if you look in fetal heart, so about halfway through pregnancy, you can see the 2 components of the atrial septum quite clearly. So if you look from the right atrium, for instance, here you can see the primary septum, which is a thin membranous structure known as the flap valve in fetal life, and then surrounding that, particularly on the upper margin, you can see the secondary septum, the fold between the atrial chambers, which we know as the rims of the oval fossa. If you look from the left-hand side, you can just about see the rims, but particularly you can see the flap valve extending into the left atrium. And you'll appreciate that the flap valve itself is a pocket-like structure. It's a thin membranous pocket rather than strictly speaking, a flap, which moves freely within the oval fossa during the cardiac cycle in fetal life. So if we look at the intact atrial septum in an adult heart, you can usually make out the two component parts relatively easily. And here I'm shining a light from the left atrium to illustrate to you the thin primary septal component, which is fibromuscular. You can see some muscular strands extending across the septum itself. And then you can see around the sides, surrounding this septal structure, you can see the secondary septal structures, or the rims. And the importance is, of course, of knowing the difference between the two septal structures is in the sense of transseptal puncture. So if we perforate the primary septal structure, or the oval fossa, then the needle passes straight from right to left atrium. It's running through a solid wall of tissue. In contrast, if we puncture through the secondary septum, so if we put a needle through the rims of the oval fossa, we do in fact go from right to left atrium. But in doing so, we have crossed the fold of tissue which forms the secondary septum, and therefore we have gone outside the heart into pericardial space, and we would risk tamponade or pericardial effusion. If we look at the intact septal structures from the left atrium, they are by and large unremarkable. You can see here that the true atrial septum is slightly lower than perhaps you might expect, and you can see above this level, you can see the crescentic rim of the atrial septum, the primary atrial septum, that's fused with the rims. So unremarkable from the left side, but from the right side, then the atrial septum is surrounded by many important structures. So here you can see the true septal structures surrounded by the rims on all sides. And if we look at the relationship of the septum then to the surrounding cardiac structures, here is the superior carpal vein, which is coming in at the top of the atrial septum. The inferior carpal vein is coming in towards the base. Here is the mouth of the coronary sinus, so slightly distant from the atrial septum in the normal situation. The septal leaflet of the tricuspid valve, again, is some distance from the atrial septum, as is the AV component of the membranous septum. And the importance of knowing the relative position of the AV component of the membranous septum is, of course, in recognizing the position of the AV node. So this will lie just below the AV component of the membranous septum, and again, in the normal situation, is away from the environment of the true atrial septum. Now, in between the coronary sinus and the inferior carpal vein, we have a very important ridge of tissue. This is the eustachian valve and the eustachian ridge, and these separate the mouth of the coronary sinus from the atrial septal structures. We'll look at that in more detail in just a moment, how this relates to the rims of the atrial septum. So if we then look at the rims of the atrial septum, then it's probably best to name them according to the structures that they are closest to. So we have a rim towards the SVC. We have a rim which is more related to the right pulmonary vein. Often we call this the posterior rim, but it may be better to call this the right upper pulmonary vein rim, and then one related to the lower pulmonary veins, one to the IVC, one to the AV valves and one to the aorta. And this often is considered to be the most important rim, particularly with respect to erosion. So important rims, and if we overlay on top of those rims the likely embryonic origin, then the anterior rim, or the AV rim, is likely formed from the muscular primary septum and as a result of fusion of the dorsal mesenchymal protrusion, whereas all of the remaining surrounding structures are effectively secondary septum. These are effectively folds between the atrial chambers. So they will lead, perforation of these rims will lead outside of the heart. So let's move on to look at some defects. Of all of the defects that we can look at, there are in fact only two, which are deficiencies of the true atrial septal structures. So the primary septal tissue that we've just been illustrating. And these are, of course, ASD secundums or oval fossa defects and patent foramen ovale. So let's look at those first of all. So patent foramen ovale anatomically is the situation where you have overlap between the two components of the atrial septum, but they are just not completely sealed to one another. So there's not complete fusion between the septum and its rims. And in essence, this will always create a channel of varying length, and there will be right and left atrial openings and a mid section to the channel. And we'll look at how that varies in just a moment. What is also crucial is the functional anatomy of the atrial septum. And I'll illustrate what I mean by that in just a moment, but it is how the septal tissue is able to move away from its rims, and that depends partly on the structure of the septal tissue and also the degree of fusion that it has to the rims itself. So let's look at an example of a simple patent foramen ovale. We're viewing this heart from behind. So the atrial chambers, the left atrial chamber is on the left of the screen, the right on the right. And here you can see the infolding, the secondary septum, both inferiorly and superiorly. And you'll appreciate very much how this is an infolding of the atrial wall. There's fatty tissue intervening between a double layer of myocardium. And here is the primary septal tissue. So this is the true atrial septum. You see that's basically fibromuscular, and you'll appreciate that it has fused in part to the secondary septal structure, but there is a small communication remaining here in the upper margin. So this is a simple PFO with probably 2 to 3 millimeters in overlap, and I think any device would fit in here quite adequately. Fairly simple defect to close. So in diagrammatic form then, in this setting, we have overlap between the primary atrial septum and the secondary septum, which is the rim. And this creates a channel with a right atrial and a left atrial opening. And the mid portion, of course, is the region of overlap. And that's the region that can vary quite markedly between patients. So let's look at an extreme example. This is a patent foramen ovale with quite extensive overlap, so-called tunnel type of PFO. And the first thing you'll appreciate as you view this specimen from the right atrial side is that the septum is slightly aneurysmal. It's bulging towards the right atrium. We have a PFO, and you can see that in the upper margin. We've got a gap here, and I can put my probe through that gap into the left atrium. If we view then from the left atrial side, you can see my probe coming through the defect, but you'll appreciate that it's having to travel vertically parallel to the atrial septum, and that the probe emerges within the left atrium very close to the roof of the left atrium. So the channel created by this overlap is a tortuous channel. It is essentially running vertically parallel to the atrial septum, and the height of the opening with the left atrium, of course, could potentially create a problem for placement of some devices. So there are many variations on that theme. There are many variations within patent foramen ovale. We can have, as we've seen, differences in the degree of overlap. We can have a septum, a PFO with a very floppy atrial septum and less amount of fusion, or one that is highly fused and very tortuous channel. We can have thickening of the septum secundum, which can create more difficulties, prominence of the eustachian valve or ridge, and additional defects. So this is an example of a PFO with a so-called floppy atrial septum. And initially you'll see that this appears to be a tiny, perhaps a tiny ASD stroke PFO. We can, if we stretch the right atrium, we can make this into perhaps an ASD. But there is a slight region of overlap initially between the two parts of the septum. If we interrogate the septum with a probe, you can see how easily the septal tissue moves away from the rims. So there is virtually no fusion between the two components, and we have a very mobile or floppy atrial septum. If we look at that from the left-hand side, you can see how we can create overlap between the two parts of the septum, the primary and the secondary. But there is the ability for the primary atrial septum to move away laterally from the rims, and there is the potential for quite a large defect, quite a large communication between the right and left atrial chambers. And so assessing this, the size of this defect, can be difficult unless you interrogate the atrial septum properly during device closure. Putting a small device in here clearly is not going to be any good. Here's an example to show you some other variations. So this is an example with quite a thick secondary septum, and you can see in this situation we have slightly more separation between the primary and secondary atrial septums, and that can create difficulties in placing some devices. The device can be brought into this channel and may not seat correctly. So an important thing to recognize before device closure. This one also has quite a prominent eustachian valve and ridge, which is inserting really into the mid portion of the anterior rim of the atrial septum. So an example here is an example from the left atrium, and you can see the PFO at the top of the picture. So there's the PFO. You can see there's a gap here between the primary and secondary septal structures. But what perhaps you won't appreciate initially is that there are additional defects in the base of this atrial septum. So there's a small hole here inferiorly, and potentially it's easy to get your guide wire through these secondary holes rather than through the expected hole through the PFO. So this again can complicate device closure. And here is a particularly complicated example. So here we have a prominent eustachian valve. We have a tunnel-like communication, which is particularly tortuous. So we look from the right side, you can see in the upper margin of the atrial septum we have a small gap. This is the PFO, so in the expected position in the cranial margin. You can see quite a prominent eustachian valve next to it, to the right of the atrial septum. And if we look at that from the left side, you can see that my probe has a great deal of difficulty entering the left atrium. There is a communication there, but there is a lot of adhesion between the two components of the atrial septum, and quite a degree of overlap between the two components. So this has resulted in a tortuous channel or tortuous tunnel like PFO, and clearly this can complicate crossing the atrial septum and potentially closure. Just looking back at the right side of the same specimen here, you can see the prominent eustachian valve and ridge. And you'll appreciate how this then may complicate closure again, because it may interfere with the right atrial disc of the device. Okay, let's move on to oval fossa defects, otherwise known as atrial septal defects of secundum type. Essentially, these can form by two mechanisms. Either the atrial septum is too short to reach the cranial margin or the rims of the oval fossa, or we can have additional fenestrations within the body of the atrial septum itself. Here's an example of the typical type of ostium secundum defect or oval fossa defect. And you can see that the septal tissue, the primary septal tissue, has failed to reach the upper margin. It's just too short to overlap the upper margin, and that's resulted in this oval shaped, irregular shaped defect within the cranial margin. There's also tiny perforation there within the body of the atrial septum, but I think that's insignificant. Here is the same case from the left side, and you'll appreciate the lack of fusion of the septal tissue to the margins, to the rims of the oval fossa. So potentially this defect could be bigger than we initially anticipate, and of course important just to emphasize interrogation of the atrial septum by some means prior to interventional closure. Here's a more difficult example. So here's an example of a multi-fenestrated oval fossa. See multiple perforations within the septal tissue, anteriorly, posteriorly, superiorly, and it can be difficult to cover all of these with one device, difficult to see all of these by imaging prior to closure. So multi-fenestrations is another variation really on ostium secundum defects, but both are deficiencies of the true atrial septum. Here again is another example which actually has a PFO and atrial septal defects. You can see PFO at the upper margin here. So there's the communication and the overlap between the septal components. And then more inferiorly, you can see three tiny holes which are close to the mouth of the IVC. These are defects within the true atrial septal tissue. And these can be particularly difficult to find on imaging when they're so close to the mouth of the IVC. This is from the left atrial aspect, just to show you those holes once again. So again, we can have many variations on oval fossa defects and on atrial septal defects of secundum type. So you've seen examples of multiple defects. In particular, the thickness or the length of the rims can be important for interventional closure. Whether the septal tissue is muscular or whether it's aneurysmal and membranous can be important. And sometimes you can get malalignment between the two components of the atrial septum, which is can create particular difficulties for interventional closure. Just to show you some variation in the size of the rims, this one is a particularly large defect. Looking at it from the right side first. So you can see here that there's a big defect. There is a rim inferiorly that I'm just probing there, but there's nothing really superiorly or behind the aorta. There's a very fine sort of muscular strand there, but nothing really surrounding this part or supporting this part of the septum itself. This is the same heart from the left aspect. And I'm showing this to you really to emphasize the fact that the primary septal tissue is very rudimentary. You can see there's these strands sort of running into the left atrium, but there's nothing that you could call a septum there at all. So this is a very big defect. You'll see there's not much in the way of rims. The rim here is in fact quite narrow, closest to the mitral valve. So I think this would be a challenge. Here's another example, still image this time, to show you, again, absent rims. So there's no rim behind the aorta. There's no rim posteriorly and very little in the way of a rim inferiorly and anteriorly. So there is only really an SVC, a rim, and a rim towards the eustachian valve. And I think this degree of anchoring, again, could create problems for device placement. Let's look at some other variations. First of all, looking at particular redundancy or aneurysmal dilation of the atrial septum. Here you're seeing the example, first of all, from the right atrial aspect. There is a right heart obstructive lesion in this instance as well. But you can see here that the septal tissue is particularly florid and aneurysmal. There are multiple holes, incidentally, in the tissue, and there's also a big PFO, or big potential ASD at the top of this defect. So very aneurysmal tissue that you're seeing from the right atrial aspect. If we look at that from the other side, so this is now from the left atrium, you can see how the tissue is effectively forming a sac, or a sometimes called a windsock aneurysm of the atrial septum. Here is the opening which we could term a PFO, because you can potentially overlap the two components of the septum. You can see how the septal tissue could potentially obstruct the valves in this case, and there are multiple secondary holes in this tissue, in this septal tissue more inferiorly. So the question is, how do you deal with this with interventional closure? Do you gather the tissue in between the discs of the device, or do you try and place a device within the major hole within the defect? So these can create particular challenges for interventional closure. Okay, let's look at some of the other types of communication between the atrial chambers, and you can see I've particularly emphasized that these are not strictly speaking defects of the septal tissue within the atrial septum. So these form interatrial communications, but these embryologically would have different sorts of origins. So we're going to look at sinus venosus defects. Superior and inferior are the types that are classically described. We're going to look at defects within or through the mouth of the coronary sinus, and we're going to look at more anterior defects, which are often termed ostium primum ASD, but in fact are deficiencies of AV septal structures rather than the atrial septum. So I've termed these pseudo ASDs because they are not, strictly speaking, deficiencies of the atrial septum itself, and really they're best explained in terms of different embryology. So sinus venosus defects are essentially a problem with the pulmonary veins, and this is the situation where the pulmonary veins, the right pulmonary veins, connect to both atrial chambers. Coronary sinus defects are similar in the sense that they are a veno-atrial malformation, and they are a connection between the coronary sinus, or the great cardiac vein, and the left atrium. They're often termed unroofing of the coronary sinus, but strictly speaking, this is an abnormal channel between the coronary sinus and the left atrium. And ostium primum defects, or ostium primum ASDs, as I said, are deficiencies of AV septal structures rather than the atrial septum, and the importance of that is that these defects are adjacent to the atrioventricular valves, so not amenable to interventional closure, and we have a difference in the structure of the AV valves themselves, in particular the left AV valve, which is characteristic, has the characteristic features of an AV septal defect in the sense that it has 3 leaflets. So let's look at some of these defects which really are not suitable for interventional closure. First of all, we have an example of a superior sinus venosus defect, and you'll see as we look at the atrial septum there is a small defect. In fact, there are 1 or 2 small defects within the septal tissue itself, but by far the larger communication between the atrial chambers is at the junction of the SVC with the roof of the right atrium, and you can see the size of this defect as I open it up, and you'll also appreciate how coming into the back of this defect we have the pulmonary veins. Now these are the right upper pulmonary veins and perhaps part of the right middle pulmonary veins, and the pulmonary veins are connected both to the right atrium as I'm showing you here, and they've retained a connection to the left atrium. And it's that biatrial connection which has created this communication between the atrial chambers. and this is above the atrial septum. It is effectively an extra, it's an extra connection between the atrial chambers, which is above the fold of tissue, the secondary septum. And then finally, the coronary sinus defect, otherwise known as unroofing of the coronary sinus. And in order to understand this type of defect, you've really got to understand the anatomy of the normal coronary sinus and its relationship to the left atrial structures. So if we look at dissection of the coronary sinus in the normal heart, normal adult heart, you can see here that the coronary sinus has its own walls. It's here running, you see it running in between the left atrium and the left ventricle. We're looking from the diaphragmatic surface of the heart. So here are the thin walls of the normal coronary sinus, normal thin venous walls. So they are completely separate from the left atrium in the normal situation. They are separated from the left atrium by the fatty tissue that you see on the outside. And there you can see the coronary sinus, the Bayesian valve there, draining into the right atrium. So normally the walls are separate from each other. In the setting of a coronary sinus defect, which you're seeing here, in this example, the atrial septal structures are intact. So there you can see an intact atrial septum. Here's the tricuspid valve. And the first thing that you'll appreciate is that the mouth of the coronary sinus is particularly large. So here's a large mouth of the coronary sinus, and then you can just about see there the communication into the left atrium. So the walls of the coronary sinus have joined on to the walls of the left atrium in this setting. And if we look then at the left atrial aspect of the same specimen, then you'll appreciate the communication between the atrial chambers, which is pretty big. And then you can see here the fusion between the walls of the coronary sinus and the wall of the left atrium. So it's an abnormal channel. It's a veno-atrial connection between the coronary sinus and the left atrium. And in this instance, there is a left SVC, but because the coronary sinus walls are missing almost entirely, the left SVC enters into the roof, or appears to enter into the roof of the left atrium. Okay, finally, let's look at the ostium primum type of ASD, which, as I've said, is a form of atrioventricular septal defect rather than, again, a true septal deficiency. So here's a heart which has, in fact, both an atrial septal defect. You can see there is very little septal tissue here, which is guarding the junction. So a huge atrial septal defect. And then this rather more oval-shaped defect anteriorly is the ostium primum defect. So you'll appreciate how close it is to the atrioventricular valves. And this is the major reason why this sort of defect is not amenable to closure with an interventional device. Looking at that from the left-hand side, again, you'll see the two defects adjacent to each other, separated by a muscular strand. And the defect that's closest to the mitral valve there is more oval shaped. That's the ostium primum defect. And you'll see how the mitral valve has effectively three component parts. We have part of the superior bridging leaflet and the inferior bridging leaflet, which are fused together and to the crest of the atrial septum, and then a third small mural leaflet to the posterior aspect of the left AV valve annulus. So an entirely different malformation, an entirely different structure of the heart to the common types of atrial septal defect. So in summary, I hope that I've shown you that our concepts of development of the atrial septum are changing, and we need to consider these when we are considering atrial septal defects. It's important and probably crucial to distinguish the type of defect, whether it's a deficiency within the true atrial septum, which would be either a PFO or an ASD secundum, from other types of interatrial communication that I've just described to you. Essentially, we need to know our anatomy, because the knowledge of the various anatomic components and knowing the variation in those components is crucial in understanding PFO and ASD, and should help correct closure of these defects by devices.